Clap already.
Yes.
Let me pause my...
Daftar saya e-logbook tau, so saya tak ada
I know.
form.
Alright. Okay, resign.
Okay. So this is a 1 year, 1 month old girl with who was admitted for 1 day history of vomiting and diarrhea with poor oral intake but normal hydration status. So she started vomiting 1 day prior to admission, about 7 episodes, but the vomiting was non-projectile, non-bilious, but large in volume, containing milk. There was no hematemesis or coffee ground vomitus. She also developed loose stools on the same day, about 3 episodes, small to moderate amount and non-bloody. It was also associated with fever. Documented temperature at home was 37.7, and mother gave Panadol at home and did tepid sponging and afebrile ever since arrival on dekat ED.
Yeah.
So ever since the symptoms onset, the child also had reduced oral intake, as she would vomit right after feeding or drinking water. However, the urine output still remains normal, and also throughout the illness, that 1 day of illness, she remains active and alert. There is positive sick contact, though her eldest sister also had AJA symptoms, vomiting and diarrhea. No recent travel history, no water activities, no URTI symptoms or urinary symptoms. This child, she is born.
Wait. So any history of eating outside?
No, sebab she fully breastfed.
How old again?
1 year, 1 month.
So mother didn't buy anything from outside.
No.
She started weaning already?
The mother said she tried. She started weaning already, tapi mostly still breastfeeding.
Okay.
So there's no history of outside food as well. Yep.
Okay.
So she was born preterm, actually, late preterm at 35 weeks, 5 days, SVD, birth weight of 3 kg. Otherwise antenatally dengan postnatally uneventful, and she is fully breastfed. Occasionally mother would give mashed rice with protein like chicken or fish dengan vegetables.
Okay.
She got no known food allergy dengan drug allergy. This is the first hospitalization. No known medical illness.
Okay.
Immunization up to date as well. So upon admission, the child generally she actually looks alert, and there's no like sunken eyes. Not the lips are slightly dry, but the oral mucosa and tongue is moist. The warm peripheries, CRT less than 2 seconds, good pulse volume, pink. Yeah.
Okay.
So then we took bloods.
So wait, don't go for blood. So based on your history and physical examination, what is your working diagnosis?
So I think this is acute gastroenteritis with poor oral intake, but maintain hydration.
So normal hydration, any dehydration?
No, sebab upon my assessment dia memang CRT less than 2 seconds, good pulse volume, lepas tu no sunken eyes, and then just the lips slightly dry, but otherwise oral mucosa moist.
Okay. So any differential of this presentation? Fever, vomiting, diarrhea, other than AGE?
It could be like tapi tapi dia tak ada URTI. I was thinking like viral infection, then sometimes they will have like loose stools macam tu.
So what do you call it? What kind of diarrhea is that? What kind of diarrhea? Patient unwell, pneumonia, then they will have this diarrhea. So what kind of diarrhea we call it? Tak tahu? Don't know.
Viral.
No. It's parenteral diarrhea.
Parenteral.
Never heard of it.
Yes.
This is all the children with loose stool because the underlying primary infection, which is can be the lung, can be the virus. Okay, some more what else? Did you add to that differential?
Can be like leptospirosis, tapi dia tak ada recent travel history or any water activities.
Okay. Alright, is this okay? So some more, what is more common other than lepto?
More common.
Fever, diarrhea, vomiting. What you have to be concerned about? Anything in Malaysia, especially fever.
Dengue.
Yes. So any AGE come with fever, you must rule out this one dengue or not. Okay. So any history suggestive of dengue?
No, they tak the housing area not prone of dengue. Lepas tu tak ada recent vomiting.
So how's the fever trend like?
Actually, since admission dah tak ada fever.
So at home, how many days for fever?
1 day.
1 day only.
Yeah.
So typically.
And dekat ED.
Alright.
Just 1 day.
So typically, how's the dengue fevers like?
It won't be 1 day definitely.
Okay, so how many days usually?
3 to 5 days.
Okay. So other than high grade fever dengue, what else dengue have?
Joint pain.
Okay.
Lepas tu rashes.
Okay, so in this age, a bit unlikely to know about joint pain or muscle pain lah. So rashes you still can probably see lah. Okay, so if dengue, the vomiting and diarrhea, are they warning sign or not?
Yes, tapi dia kena tengok frequency also.
Okay, alright, but you can label then the dengue with warning sign for AGE. So how do you differentiate? This is basically AGE or dengue?
Kalau dengue sebab dia ada different phases, so we can monitor and see the fever trend. And then we investigation can help.
No, just from the history.
The history, kalau housing area dia ada recent vomiting,
alright.
and then the child has like 3 days history of fever. Lepas tu it doesn't help with like Panadol juga, also ada rashes, joint pain.
And AGE?
Kalau AGE, especially kalau dia viral cause of AGE, the fever will be low grade and then like short duration. Lepas tu with like supportive management, then it will be
okay. So this patient, the predominant symptom is what? Diarrhea, vomiting? Vomiting. So what the first symptom that patient has? Vomiting lah. So you started with vomiting first, and
vomiting, then diarrhea, and then fever.
Okay, so that's the big clue to tell you this one. What is the possible source of ni lah? Then the fever comes probably related to it lah. Most of the time you want to know if you dehydrated, you have some gut infection, you may have fever as well. Most of the time dengue, they predominantly just fever alone. Then the vomiting, diarrhea comes after when they have a warning sign lah, depend on the severity of the dengue. Okay, alright. So what about the blood investigation?
Okay, so investigation we send for FBC RT dengan stools for rotavirus and culture and sensitivity. The FBC actually we noted HB low dengan MCV and MCH. So we're thinking of like iron deficiency anemia because that's the most common one. Plus the mother said the child is like mostly breastfed. So
Okay.
and then
So what do you want to see specific to AGE?
nak tengok white cell and also the differentials count.
Okay.
I have it here. So dia punya white cell is not raised, 10.5, and it's actually neutrophilic predominant, but white cell is not raised.
Okay. So as do you say?
And then renal profile.
What you want to see?
Because we want to see the sodium, potassium, urea, and creat. Sebab takut dia dehydrated, and then AKI. Tapi tak. Okay je. And then stool for.
What about the sodium and potassium? What you want to be worried about?
The sodium, because if we start IV drip, then we need to know a baseline of dia punya sodium, potassium, and then after that we don't want, kalau the patient has like SIADH or ataupun like like if we give drips.
So in related to AGE, what can happen to your sodium and potassium?
Low.
Why?
Sebab you are losing electrolytes.
Okay. So dehydration also you can classify based on the sodium level. What are they?
Mild, moderate, severe.
No, based on sodium level. What kind of dehydration is that? You can label it based on the sodium. If low sodium, you call it this dehydration. If high sodium, you call it
hyponatremic.
Yes. Dehydration. If sodium is high, hypernatremic dehydration. Because that's how sometimes we classify what kind of dehydration other than 5%, 10%.
So that helps us with like what kind of fluids we want to give.
Yeah, it helps with the fluids management what kind of drip you want to give. Okay, so if hyponatremic, what kind of drip you want to give?
We can give normal saline.
Okay.
Kalau hypernatremic, we can give half.
No, that's the wrong concept. Okay. So, no, it's basically the drip is always normal saline. We don't go with hypotonic saline per se lah, unless child 1 month old and less lah. Anything more than 1 month, we stick to normal saline lah. Back then, during my time, housemanship, everything, everybody get half saline lah from 1 month, 6 months, everything. But we're moving away to hypotonic solution already. Everything is isotonic. Okay, so what can happen if we give hypotonic solution, like sodium 160, then you give hypotonic solution to bring. What can happen in hypernatremic dehydration if you give isotonic? Severe edema. Okay, alright. And then if you give in hyponatremic dehydration, if sodium is very very low, then you bring up your sodium too fast, what can happen? Let's say from 120, you bring up to 135 within 24 hours. It's too fast. Do you know what's the appropriate rate? In 1 day, how much sodium you can correct?
No.
Don't know. Okay, but if you correct too fast, what can happen? Sorry?
Acidosis.
No. Acidosis can be because of the saline itself. But what can happen to the brain if you correct too fast?
Edema.
No, cerebral edema only if you bring it down too fast.
The opposite.
No, it's not the opposite. Something happened to your neurons. What can happen? Don't know. Can have seizures, but what's the condition called? Cerebral? Tak pernah dengar. Cerebral pontine? Tak pernah dengar. So cerebral pontine myelinolysis. Your myelins can get disrupted, can get destroyed because of sudden shift of sodium. Everything can shift to acetaminophen, cause edema, cause it rupture lah. So from normal child can become abnormal child. It's that bad. Okay, then cerebral edema.
And it's permanent?
Yes, it's permanent. Nerve everything once rosak lah. Okay, then if you bring your hypernatremic too fast, you also get cerebral edema. Do you know how the cerebral edema can happen if you bring your sodium too fast?
Like I know because like water will always follow sodium. So if we bring down too fast and then the water shift to extracellular, then causing.
So when you have hypernatremia, the osmolality in your vascular is very high. Okay, then it will shift your fluids from your brain to the intravascular, right? So your brain shrunk, but body will prevent it to happen. We prevent the brain shrinking. Brain cannot shrink. Alright. Yeah, if brain shrink, habis lah. Alright. So they will produce a lot of osmoles to maintain their osmolality. Okay. So when they bring up their own osmolality by using their own thymine, whatever protein inside all this, the brain, so increase osmolality. So it kind of like level the osmolality become the same to prevent the brain shrinkage. So when you put in hypotonic saline, it's very hypoosmol, very diluted. Okay, so that's why you fluid will shift from vascular to your brain tissue, so it can cause cerebral edema lah. Okay, so the cerebral edema also can be disastrous lah. What can happen? What's the worst thing can happen in cerebral edema?
This thing.
Brain shrink. Dah lah. They can get coning. They die lah. Alright. So, okay, I will ask you how to manage cerebral edema lah. Okay, so, alright. So you said normal hydration. So what kind of fluids, drips you want to give?
Normal saline.
Normal saline. Okay. Got D5 or no D5? D5. Okay. So children, because they don't eat properly, right? So they cannot be hypo lah. So D5, D10 depends on the sugar level. So nothing is fixed. Normal saline is for everyone. Everything follow every patient need. Okay. If low, you give sodium lah. If too high, you can use half saline D5 after you use your normal saline first. But since the level doesn't go down, that's when you can start using your hypotonic solution lah after your isotonic. Okay, if the level still persistently high, but most of the time, the hypernatremia because of the body lost water. Okay, alright. So if you want to start correction, how do you count the correction?
We tengok dia how many percent of dehydration first. So if let's say we say 5%, so we use 5 divide 100, so times your body weight, and then times 1000. Then so that's for correction. Tapi we also
after that divide how much?
See how in what duration we want to correct.
What's the appropriate duration in terms of correction? How long you give?
Like 12 to 24
Too fast.
2 days.
48 hours. Usually we can't deficit 2 days lah. Anything more than that is depends on the clinician lah. But don't just follow. But appropriate time is always 48 hours lah. Okay. Because you still have your maintenance strip, so it's gonna be a lot. Okay. So you don't want fluid overload lah most of the time. Okay. So after you count your correction, then you start your maintenance strip. So what you want to do? How you want to monitor the patient after you start your trip?
Strict IO charting.
Okay.
And then encourage orally. And then also temperature charting, tengok ada fever lagi ke tak. And then
okay, so what you want to do on the vomiting and diarrhea? want to give, or you advise patient ORS. So how much you give the ORS?
Kalau dia normal hydration in this case, we just use 10 ml per kg.
Okay, so how you want to tell mother to dilute the thing?
200 cc water.
About 1 cup lah.
Yeah, 1 cup.
One small, one standard cup, not
Yeah.
small. Okay.
Then larutkan. Lepas tu, if the child vomit, then let the child vomit first. Wait for like 10 minutes macam tu. Then baru bagi the ORS again.
So mother ask, doctor, can campur in susu or not? So what you will tell her?
Cannot.
Why?
Sebab
What's the reason?
sebab nanti the electrolytes.
Something to do with electrolyte. Which electrolyte?
Sodium.
Sodium lah. It can cause hypernatremia. It's already a lot of sodium inside your formula. You add some more sodium. Okay. So better eat separate, drink separately lah. Okay. Most of the time children tengah AGE they cannot tolerate lah susu. Okay. Alright. So I'm gonna ask a bit of emergency question related to this. So a patient vomiting diarrhea, what kind of shock they can have? Hypovolemic shock. So how many shock are there? 4.
Cardiogenic, distributive, hypovolemic,
obstructive. Okay. So if patient, let's say your patient in the worst case scenario comes very profuse amount of vomiting and diarrhea, come in very dry, heart rate 190, BP still okay. So how you want to
treat as hypovolemic shock? So kita ikut ABC thing. Make sure the airway is latent. Lepas tu insert 2 lines so that one can form Menderes, one can form the deficit, and then
okay.
And then
what kind of bolus you want to give?
Crystalloid, so normal saline.
Okay. How long you want to give the saline? Bolus. How long? Bolus normal saline, how long you usually give?
Depending on the line yang kita insert.
Okay, but in standard, what is everybody ordering the same?
1 hour.
Yeah, 1 hour less standard. Can go faster. You can even push it in yourself with the syringe. Okay, depending on how bad the dehydration lah. It's very bad like that. Shock come very dry. Not just, then you can give push bolus lah. And you push yourself. If not, then you just pakai infusion pump. Give for 1 hour. Okay, so if the patient datang very severe like that, shock like that, so most of the time you want to cover with bacterial infection ke tak?
Yes.
Okay. What kind of bacterial infection can cause vomiting diarrhea very bad? Okay, the virus one, I'm sure you know what kind of virus.
Rotavirus.
Okay, then bacteria?
E. coli.
Okay. Some more? Have you worked before food and beverage industries? No. I see anyone food before?
Typhoid.
Yes, they have to take what injection? Typhoid. So
Typhoid.
typhoid also one of the possible bacterial causes lah. Okay. Typhoid is what? What full name of the typhoid? What's the genus? Typhoid is the species. What's the full name of typhoid? What's nama depan dia? What's the first name? Typhoid is typhoid lah. It's something typhoid. No. Salmonella. Salmonella typhoid. Okay. So any salmonella infection also can have diarrhea lah. Not necessarily typhoid lah. Non-typhoidal punya salmonella lah. Okay. So you eat outside everything semua, it's possible you can get typhoid as well lah. Can get into sepsis one not. Okay. So let's say you already give bolus, patient, BP, heart rate coming down but still tachycardic, you give second bolus, third bolus, still tachycardic, BP on the lowish side. So you started your maintenance, you started your correction, but somehow BP just hanging there, slightly low. So what you want to do? You serve antibiotic already, that BP still not normalized yet, already 3-4 bolus.
Support the BP.
We what?
NORAD.
NORAD. Why NORAD?
No. Okay.
So you don't simply start. There must be a reason you start certain thing lah. Can be adrenaline, can be noradrenaline, can be dopamine, can be Merinon, can be dopamine and all that lah. But in terms of choice of antibiotics, usually, and choice of inotropes, it depends on patient's condition lah. Don't simply start something without reasoning. Okay. So the reason you want to choose NORAD, why? Think. Patient datang very bad like this, vomiting, diarrhea, fever, sepsis like.
Sebab dia losing into third space.
Third space ah? Third space is dengue. This patient vomiting, vomit outside.
Like outside. Yeah.
Okay. Don't know.
Not sure.
So in general, inotropes, if patient septic shock ke apa ke, this patient could be having hypovolemic shock plus septic shock. So lah, if patient become very very bad like that. Sometimes you already rule out sepsis, then it's just hypovolemic lah. But if they have two together, it's still a possibilities lah. Okay. So NORAD, most of the time we start because of septic shock they have, white pus pressure lah. So you want to vasoconstrict, normalize the pus. Okay. So in hypovolemia, not much, no specific inotropes can start. You can start dopa. That one the most simple inotrope everybody will start. Okay, but the problem with dopamine can cause very bad tachycardia lah. Okay, so NORAD for septic shock. If the heart function is not good, then you start what? Tinggal apa lagi? What else do you have left? Adrenaline. So whatever it is you cannot think what to start, you just start adrenaline. You probably cover a lot of things already. Okay, in terms of inotropes, the true inotrope is always adrenaline lah. It should help with your septic, it should help with your hypovolemia, it should help with your heart function or myocardial injury whatnot lah. So it should cover everything lah. Okay. Alright. Okay dah. Kita anything kan pasal nak? So the e-logbook how to masukkan? I don't know.
E-logbook
Dr. Hana.
Hana
Okay lah, I'll tell Dr. Hana later lah.
Yeah.
Alright. Okay.
Thanks, Dr. Hana.
Welcome.